So at the outset, I would like to thank AIOS, ARC, Dr. Somashila Murthy for having me here. So without wasting much of time, I would be just going on to the management of dry eye case-based scenarios. What? Before we really go to the cases, just a brief review of what dues to guidelines are. So most of the cases of dry eyes that we see in our scenarios are usually either the evaporative type of dry eyes or the mixed form of the dry eyes, and very few are usually the aqueous deficient dry eyes. Now, these could be asymptomatic, symptomatic, with ocular surface signs. So it's when we look at a dry eye disease, it's multifactorial. Many times, the patients present with very variable symptoms and signs. So once you have a clinical suspicion, and if OSDI score that you have assessed on your clinical history is high, it's mandatory to perform certain diagnostic tests in order to assess the presence of dry eyes, the severity of the dry eyes, and the type of dry eyes. Some of the diagnostic criteria tests which have been recommended are usually, can you see that? Yeah, okay. The tear breakup time, which could be the non-invasive or a fluorescent tear breakup time, tear osmolarity, and the ocular surface stain, which is a very, very important tool in the diagnosis of dry eyes. Coming to meibography, it's not been recommended as a diagnostic tool, but it's one of the important tools which helps us differentiate meibomian gland disease from the aqueous deficient dry eyes. So the picture on the left top is a normal meibography, and the rest of them show variable amount of the meibomian gland dropout that you see. So normally you do not see the MGD dropout in the age group of less than 20 years, and those about 20 years you should be only able to see about 25%, which should be considered as normal. But if you see more of it, it's considered to be pathological. It helps us differentiate between a patient who comes to you with a non-specific symptoms, who could be a normal patient versus a patient with dry eyes. It can differentiate between evaporative and aqueous deficient dry eyes. It usually tends to correlate well with your NIBUT, with your OSDI score, and with your lipid interferometry. And it does not have any predictive value in terms of the therapy. So if you have given some patients some therapeutic treatment and you want to see whether meibography improves, it really does not. This is just a small table where I've tried to divide the types of dry eyes. So if you have a tear breakup which is normal, but you have all the other tests which are positive, like Schirmer's or tear lipid or MGD dropout, it's a subclinical case of dry eyes. And if you have a tear breakup which is affected, with Schirmer's which is affected, you know it's an aqueous deficient. If it is a MGD case, you have a lipid which is abnormal, or you have a MGD dropout, then it is a evaporative type of dry eyes. And when everything is affected, you know it's a case of severe dry eyes. Coming to the treatment, it should be a tear film oriented therapy. So if you have a lipid layer deficient dry eye, you use ointments and you use warm therapy, you use lid compresses and heat therapies which are available in the market. For aqueous deficient dry eyes, usually it is the tear lubricants and punctal occlusion. And when you see a mucin deficient dry eyes, something like an OCP, you need to use some mucin secretagogues like rebapamide. However, it's not available in the market now. And inflammation on the ocular surface needs to be managed with the anti-inflammatory drugs. You need to have a stepwise approach, which has been recommended by the dues to guidelines. So coming to the cases, this is the case number 1, which is a 69-year-old female who was referred for cataract surgery to my practice. Her best corrected vision was 6/24, and when you look at the stain pictures, you can make out that there were diffuse SPKs in both the eyes, the left eye more than the right. She was investigated for rheumatoid arthritis, which turned out to be positive, and was referred to rheumatology clinic for starting her on immunosuppressive. Now, she was on topical CMC and the cyclosporin eye drops, and we continued to review her, and at the end of 2 months, we still had the patient having persistent SPKs. Her Schirmer's had improved to 6 millimeter and 2 millimeter in both the eyes from 4 and 0 millimeter. So at this point of time, when we wanted to visually rehabilitate her, we decided to go ahead with punctal cautery of all punctae. And at 1 week post-op, you see a dramatic effect. The right eye, the surface clears. The left eye, you just have a few SPKs. Schirmers with anesthesia improves to about 15 and 12 millimeter. So we go ahead with cataract surgery in another week, and we could restore her vision back to 6.6 with a very stable ocular surface. Another patient, 28-year-old female, who comes to you with redness and pricking sensation. She was a known case of rheumatoid arthritis since 2017 and was on immunosuppressive therapy. When you look at her ocular surface, she had a poor lower tier meniscus. Her Schirmer's test 1 was 3 and 5, while that with anesthesia was 0 millimeter. So this is the dry workup which was done. So you can see the infrared picture showing a very low tier meniscus, the ocular surface stain positivity. This is the meibography which was normal. This is tear breakup time. So you can see that both eyes were affected. The right eye was more than the left eye. And this is the lipid interferometry, where you can see that the right eye is a totally broken lipid layer. You can't make out a continuous lipid layer. Left eye had some amount of continuous lipid layer. So this patient was put on HPMC eye drops along with CMC gel and cyclosporin eye drops. Her Schirmer's one improved slightly. However, that with anesthesia did not improve, and this patient got lost to follow-up. This is the third patient who has undergone SMILE 6 months back and had a persistent complaints of discomfort on the computer use. So this is her tear evaluation. So you can see that she had Schirmer's 2 values which were low, and if you look at her meibography, there was a significant amount of gland atrophy. There were pouting of the meibomian gland openings with a little viscous lipids coming out. Look at the NIBUT, which was relatively okay, except that the left eye was slightly decreased, and the tear film lipids, you see a continuous gray film, which probably is either normal or it's a little low. So this patient was diagnosed to have a combination of ADD and MGD, unlike what we would call it as a neurotrophic cornea having a purely refractive surgery-induced dry eyes. And this patient was put on lubricants along with oil-containing ointments with warm compresses and lid massage. And at the end of 6 months, her Schirmer's 2 values improved to 5 and 8 millimeters. There's another patient who was a long-term contact lens user with symptoms of dry eyes. His lower tier meniscus was good, but if you see the meibomian glands, you see a significant amount of gland dropout on both upper and the lower lids because of the contact lens overuse. This is another patient. So this was an 83-year-old female, right eye asymptomatic, a known case of idiopathic lung fibrosis. In the left eye, she had sudden deterioration of her symptoms since few days. And when you look at her, she had a corneal melt with Siddle's positive in the central corneal area. So this patient was advised to undergo a Tenon's patch graft with AMG, which was done immediately. She was put on, she was already on immunosuppressive and a low dose of oral steroids. Her oral steroids were stepped up, and she was advised to start topical prednisolone eye drops in a tapering dose. And her surface improved significantly, and at the end of about 2 years, she's having a vision of 6/12 in the left eye with a stable ocular surface. This is another patient, 47-year-old female, had undergone cataract surgery in the past. Known case of arthritis since 10 years, but was off the treatment. And again, in the left eye, she had sudden deterioration of her symptoms, and the vision was finger counting 1 meter. And if you see here, the right eye was showing a diffuse SPKs, and the left eye was showing a central corneal melt. Though there was no leak, Siddle's was negative, there was a irregular anterior chamber. So at this point of time, patient was advised to undergo a Tenon's patch graft, but she deferred. She was put on oral steroids immediately along with lubricants and cyclosporin. And within 2 days, her ocular surface actually stabilized. And at the end of 6 months, we can see that there is a very good amount of ocular surface stability that we have got. The problem with this patient is compliance. And at the end of 6 months, she had stopped her cyclosporin. And you can see that the surface is again showing some stain positive areas.
Can we see?
Okay. So this is my last slide. This is a patient of uh, uh, who came with symptoms in the left eye more than the right eye. And I'm so sorry, this is the same patient. I'll just skip it. Yeah, so just a last slide of hypersecretory type of meibomian gland disease. So this patient, if you see the lid margin, it's quite inflamed in the left eye with the posterior migration of your meibomian glands. And when you look at the tear breakup time, it's poor in the left eye. And if you look at the lipids, the right eye shows a very good gray continuous layer. The left eye shows a very, very hyper colored tear lipids. So this is basically a thick layer of lipid layer, probably which we see in hyper secretory variant of meibomian gland disease. And one has to actually look at the inflammation as one of the component here and treat that instead of treating it as a pure dry eyes. So conclude, a careful diagnostic evaluation is must. We must include lower tear meniscus height, tear breakup time, Schirmer's, and possible MGT evaluation in our diagnosis. Stepwise therapeutic approach usually provides a good ocular surface, and punctal occlusion in case of non-responsive cases really stabilizes the ocular surface. Surgical management is needed when you see a surface breakouts, and meibography is definitely helpful in diagnosis of meibomian gland disease, which usually would respond to your heat therapy. Thank you.